Alright, it's been a while. So recently I got sick and I didn't have the voice or the energy to do these videos. But now I'm back. So let's jump back to where we left off with the in-depth review of Flashcards 21 through 30. My name is Zach and this is Paramedic Zach. Alright guys, again, thanks for joining me, and we're going to be jumping back to question 21, which was, which 6 treatments in order can be used to treat COPD and asthma? Now obviously there's a lot you can do for asthma and COPD, so I put a hint here as to what I was kind of looking for with this question, and the hint that I included is that 5 of the answers are going to be medications. So in order to treat asthma and COPD, you're going to use albuterol, Atrovent, your CPAP, epinephrine, solumedrol, and magnesium sulfate. So COPD stands for chronic obstructive pulmonary disease, and asthma is actually part of COPD. COPD is kind of like a blanket term for 3 underlying conditions: asthma, emphysema, and chronic bronchitis. Asthma can be defined as a reversible narrowing of airways, usually caused by a white blood cell called an eosinophil. Emphysema is an actual destruction of the lung tissue, the alveoli. And lastly, chronic bronchitis can be defined as a chronic excess in mucus production. Oftentimes you'll see that chronic bronchitis and emphysema go together. That is, your emphysema patients will typically have chronic bronchitis and vice versa. Asthma, emphysema, and chronic bronchitis can cause inflammation of the lung tissue and can ultimately lead to tissue death. Damaged lung tissue diminishes the lung's ability to effectively inhale and exhale. This leads to something known as air trapping, where the air in the lung cannot be fully exhaled and some of the air remains behind as dead air. Dead air is stagnant air, which means this air is not moving. If the air cannot be recycled within the lung, then new oxygen molecules cannot be exchanged. The combination of air trapping, tissue death, and mucus production results in a substantial reduction of gas exchange within the lung. This means that oxygen can't get in and carbon dioxide can't get out. Thus, you have a buildup in CO2 levels and a drop in oxygen levels. See, normally your brain signals your body to breathe when you have an excess of CO2 in your body. But because the bodies of our COPD patients are so used to an increase in CO2 levels, it switches to something known as a hypoxic drive. Instead of breathing when your body has too much CO2, their body is breathing when they don't have enough oxygen. Since their body relies on a reduction in oxygen levels in order to breathe, increasing this patient's SpO2 to 100% would decrease the patient's respiratory drive. Long story short, be careful when you're administering oxygen to your COPD patients. Alright, so let's move on to treating COPD. Treatments 1 and 2 kind of go together. Both albuterol and Atrovent are going to be given together through a nebulizer. For albuterol, your adult dose is going to be 2.5 milligrams, and your pediatric patients are going to get half the adult dose at 1.25 milligrams. Atrovent is going to be given at a dose of 0.5 milligrams for the adult, and again, the pediatric patients are going to get half the adult dose at 0.25 milligrams. So let's first review how albuterol works. Albuterol is a beta-2 agonist. It stimulates the beta-2 receptors found in the smooth muscle of the lungs. Stimulation of the beta-2 receptors dilates the smooth muscle, causing bronchodilation. Albuterol is going to come dissolved in normal saline and is going to be packaged in a small plastic bullet. Each bullet is 2.5 milligrams. Atrovent is going to be packaged similarly and is going to be 0.5 milligrams per tube. Both of these medications, albuterol and Atrovent, are going to be delivered together in the nebulizer. Atrovent, aka ipratropium bromide, is an anticholinergic medication. That is, it blocks muscarinic acetylcholine receptors. This has the effect of decreasing mucus production and dilating the airways. However, since both of these medications rely on your patient's ability to effectively inhale, your patient might need some help. Your third treatment for your COPD patients is going to be using your CPAP. Again, CPAP stands for continuous positive airway pressure. Now, there are quite a few contraindications for using your CPAP, so listen up. Your contraindications include respiratory arrest, a decrease in level of consciousness, a pneumothorax, face and neck trauma / burns, and vomiting or secretions. Of course, you can see how any of these conditions might preclude a patient from using a CPAP. The pressure of a CPAP is measured in centimeters of H2O. Typically, you'll see pressures of 5 to 15 centimeters of H2O on your EMS CPAPs. The oxygen tubing is connected to the high pressure valve on your regulator. Since the CPAP has an attachment for a nebulizer, albuterol and Atrovent can be given during use. The pressure from the CPAP forces open the collapsed bronchioles, allowing for better gas exchange and for the medications to be delivered. However, if your patient is still in respiratory distress, you can consider administering epinephrine. Epinephrine is going to be given intramuscularly at a concentration of 1 to 1,000. Adults will get 0.3 to 0.5 milligrams, while pediatric patients will get 0.15 milligrams. Epinephrine, like albuterol, is a beta-2 stimulator, which gives us some more bronchodilating effects. Next, after establishing an IV, consider giving an IV steroid, such as Salumedrol. The dose for an adult will be 125 milligrams, while your pediatric dose will be 2 milligrams per kilogram to a max of the adult dose, 125 milligrams. Salumedrol is going to be best for your patient in the long run. However, it doesn't really have any effects until about 1+ hours. Steroids work on the beta-adrenic receptors, promoting bronchodilation and systematically reducing inflammation. Lastly, it's been found that increasing circulating serum levels of magnesium in the body has bronchodilating effects. For severe bronchospasm, you can administer magnesium sulfate IV. Your adult dose is going to be 2 grams over a period of 10 minutes, and your pediatric dose will be 25 milligrams per kilogram to a maximum of 2 grams over 5 to 10 minutes. In order to give your magnesium over a period of 10 minutes, what you're going to want to do is inject your magnesium sulfate into a 100 milliliter bag of normal saline, and you're going to give 2 to 3 drops per second using a 15 drop per milliliter drip set. And lastly, remember to always recheck lung sounds. Question 22. What is the criteria needed to diagnose LVH, or left ventricular hypertrophy, on an ECG? The answer here is you're going to take the deepest S wave from leads V1 and V2 and add it to the tallest R wave from leads V5 and V6. If the sum of these two values is greater than 35 millimeters, then it qualifies for LVH. So what exactly is left ventricular hypertrophy? LVH is an abnormal thickening of the left ventricular wall. This can cause a decrease in the volume of blood pumped. LVH typically occurs when the heart is forced to pump blood against an increase in pressure. This pressure is known as afterload. Two of the most common causes for an increase in afterload are hypertension, which is high blood pressure, and aortic stenosis, which is a narrowing of the aorta. The thickened heart muscle generates a larger QRS voltage on the ECG. If the voltage is large enough, then it's classified as LVH. Let's go over an example. Here, you're going to take the deepest S wave from leads V1 and V2. Here it looks like it's V2 at 30 millimeters. Then you're going to add that value to the tallest R wave from V5 and V6. Here it looks like V5 at 19 millimeters. You take 30 plus 19 and you get 49 millimeters, which here is greater than 35 millimeters. And in this case, the patient would be positive for left ventricular hypertrophy. Question 23. Treat congestive heart failure with Lasix at a dose of 40 milligrams IV or 2 times the patient's daily dose to a maximum of 100 milligrams. So first, let me say that many systems seem to be phasing out Lasix as a pre-hospital treatment. Studies have found that the pulmonary edema associated with CHF is more of a fluid distribution problem rather than a fluid volume problem. Let's first review how CHF works with the segment from episode 1. So first, let's start off by defining what CHF is. Well, CHF is congestive heart failure. It's a type of heart failure which causes congestion within the circulatory system and in the lungs. So keep in mind that the right side of your heart pumps deoxygenated blood to your lungs so that that can become oxygenated and circle back to the left side of your heart where it's pumped out to the rest of your body. The path of blood is simply way heart to lungs to heart to body to heart. And this is a continuous loop so that your body can be systematically perfused. However, if the heart is weakened or injured, then the heart only pumps out a percentage of the blood it receives, and it backs up into the lungs and into the circulatory system. The body then retains fluid, and the result is pulmonary edema and hypertension and peripheral edema. The pulmonary edema stresses the lungs and causes breathing problems, where the hypertension and peripheral edema stresses the heart and can cause chest pain. Treating CHF with nitroglycerin dilates the blood vessels, decreasing vascular resistance and taking stress off an already damaged heart. This takes stress off the pulmonary vasculature as well, and it reduces pulmonary edema. Lasix is what's known as a loop diuretic. A loop diuretic inhibits sodium from being reabsorbed into the bloodstream. Instead, the sodium collects within the tubules of the kidneys. As water follows salt, water is pulled into the kidneys where it and the sodium are excreted. Since CHF is a fluid distribution problem and not a fluid volume problem, there's the potential for dehydration and electrolyte imbalances. But if your system does use Lasix, the dose is typically 40 milligrams or twice the patient's daily dose to a maximum of 100 milligrams. Question 24. This is going to be a quick one. So during pregnancy, the resting heart rate increases 20 beats per minute. So during pregnancy, the heart must pump more blood to the uterus and fetus. The cardiac output can increase 30 to 50%. So in order to pump the increase in circulating blood volume, the heart rate will increase approximately 20 beats per minute. Moving on to question 25. Use a 14 or 16 gauge needle for a needle cricothyrotomy. So a needle cricothyrotomy is a procedure used to gain access to an otherwise occluded airway. The occlusion can be anything from swelling to a foreign body. But as long as the occlusion is above the cricothyroid membrane, a needle cricothyrotomy can give you airway access. After locating the cricothyroid membrane, which is between the patient's Adam's apple, which is the thyroid cartilage, and the bump directly below that, which is the cricoid cartilage, you're going to insert a 14 or 16 gauge needle attached to a syringe at a 45-degree angle towards the patient's chest until you can aspirate air. Then remove the needle/syringe while advancing the catheter. What you do next will depend on where you work. If you're using a jet ventilation setup, then the breath is delivered using the high pressure valve on your oxygen regulator and some oxygen tubing. The air is delivered incrementally with a trigger or a freeway stopcock to the desired tidal volume. However, if you don't have one of these fancy machines, I'll take you through the MacGyver way. You can either 1. Remove the BVM adapter from a size 3 endotracheal tube and connect it directly to the catheter, or you can 2. Connect your catheter to a 3 milliliter syringe with the plunger removed, and then connect the BVM adapter from a size 7 endotracheal tube to the top of the syringe. Each method will allow you to ventilate your patient with varied effectiveness. As with any other airway you might establish, always look for equal chest rise, listen for equal breath sounds, and utilize your end-tidal CO2 and SpO2 monitoring. Question 26. If adenosine does not work in treating a stable, narrow complex tachycardia, then try either a calcium channel blocker or a beta blocker. First, let's review what adenosine is and how it works with a segment from episode 2. The medication that we're going to be giving to our SVT patients is adenosine. Adenosine works at the AV node in the heart. It slows conduction time through the AV node by altering the electrical gradient existing within the heart's electrolytes. Adenosine is first going to be given at a dose of 6 milligrams, followed by a saline flush. However, if this doesn't work, you can give a repeat bolus at a dose of 12 milligrams with a rapid saline flush. The reason the saline flush is so important is because adenosine has an incredibly short half-life, roughly 10 seconds. This means it can decay before it even has a chance to get to the heart. A saline flush is going to help push the medication through to the heart and to the AV node. Lastly, adenosine has also been found to affect the SA node, reducing the number of impulses sent from the SA node to the AV node. Fun fact about adenosine is that caffeine works by blocking the adenosine receptors in your brain from being stimulated. Then when the caffeine wears off, all the pulled up adenosine overwhelms the adenosine receptors and you have your typical caffeine crash. A calcium channel blocker or a beta blocker is the first medication used in treating atrial flutter and atrial fibrillation with rapid ventricular response. See, oftentimes with AFib with RVR, the rate can be so fast that it's near impossible to pick out any irregularities and it can appear as SVT. So if your patient is not responding to adenosine, try a calcium channel blocker or a beta blocker. It could be AFib with RVR. However, mixing beta blockers and calcium channel blockers can be really dangerous. For this reason, if your patient already takes a medication in one of these classes, you're going to utilize a medication from the same class. Typically, if you're giving a calcium channel blocker, it's going to be Diazepam, and if you're giving a beta blocker, oftentimes it'll be metoprolol. Your Diazepam dose is going to be 0.25 milligrams per kilogram delivered slowly via an IV. You can give a second dose after 10 to 15 minutes if needed at a dose of 0.35 milligrams per kilogram, again given via IV slowly. If you're giving metoprolol, your dose is going to be 5 milligrams per kilogram. You can give this medication up to 3 times in intervals of 5 to 10 minutes if needed. Again, you're going to give 5 milligrams per kilogram and you're going to deliver this medication IV and slowly. When I say slowly, you're going to want to give this medication over the period of 2 minutes. This is so you can monitor the patient's heart rate and blood pressure as you're giving the medication and titrate to the desired effect. Question 27. Which leads do you look at to determine axis deviation? The answer here is going to be leads 1 and AVF. Axis of your heart is the main direction of electrical flow. An electrical impulse usually begins at the SA node, moves down to the AV node, and down the bundle of His and out to the Purkinje fibers. Thus, on a normal 360-degree circle, we can say that the axis of a normal heart is approximately 135 degrees. This circle is divided into 4 quadrants, each representing their own degree of axis deviation. Picture an arrow going from the center of the 4 quadrants out towards any direction. If that arrow lands within the bottom right quadrant, it's going to be categorized as normal. In the bottom left quadrant of our circle, we have right axis deviation. In the top left corner of our circle, we have extreme right axis deviation. And then finally, in our top right quadrant, we have left axis deviation. Again, if you draw a line from the center of the circle towards the perimeter in any direction, whatever quadrant that arrow lands in will be its axis. So how does this relate to a patient in the field? You can determine axis deviation by looking at your QRS complex in leads 1 and AVF. What you're looking for is if the QRS complex is predominantly negative or positive. If you're good at remembering images, there's a particularly helpful chart to help you remember axis deviation. Again, you're going to be looking in leads 1 and AVF. Again, if the axis falls within the bottom right quadrant of our circle, we're going to have a normal axis. On an ECG, this is going to appear as 2 pointy hats in leads 1 and AVF. Pointy hats being a positive deflection of a QRS complex. With right axis deviation, that is an axis that falls within the bottom left quadrant of our circle, you're going to see a funnel shape representing a negatively deflected QRS complex in lead 1. You're also going to find a pointy hat or a positively deflected QRS complex in lead AVF. Extreme right axis deviation, that is an axis that falls within the top left quadrant of our circle, you're going to find both funnels in lead 1 and AVF, that is a negatively deflected QRS complex in both leads 1 and AVF. Finally, with left axis deviation, which is an axis that falls within the top right quadrant of our circle, you're going to see a positively deflected QRS complex in lead 1 and a negatively deflected QRS complex in lead AVF. That was a mouthful, but I know that the image tends to be more helpful than the actual explanation. So try to remember that chart if you can. So what are some of the causes for axis deviation? Well, there's actually a whole list available as to what can cause each type of axis deviation, and I'll give you some of the examples right now. Right axis deviation can be caused by a right bundle branch block, right ventricular hypertrophy, a pulmonary embolism, a lateral STEMI, COPD, I like that better. COPD, hyperkalemia, TCA poisoning, Wolff-Parkinson-White disease, ventricular ectopy, and it can also be a normal finding in pediatric patients. Extreme right axis deviation is caused by ventricular rhythms, hyperkalemia, and severe right ventricular hypertrophy. Lastly, left axis deviation can be caused by a left bundle branch block, left ventricular hypertrophy, Wolff-Parkinson-White disease, and a ventricular pacer or ventricular ectopy, and an inferior MI. Moving on to question 28. What is the adult diazepam dose for treating delirium tremens? And the answer here is 10 milligrams IV. So let's first review how Valium, aka diazepam, works. Valium is in a class of medications known as benzodiazepines. This is a class of medications that includes diazepam, Valium, lorazepam, Ativan, midazolam, Versed, and many others. Benzodiazepines are known for their sedative effects. They work by enhancing the effect of your GABA receptors in your brain. GABA is the brakes of your nervous system and is responsible for slowing everything down. In other words, GABA is the chief inhibitory neurotransmitter. Now let's take a look at the condition known as delirium tremens. Delirium tremens is a state of severe alcohol withdrawal. DTs typically occur approximately 3 days after discontinuing a period of heavy drinking. DTs can present with confusion, hallucinations, shaking, and even seizures. You might also see hypertension, fever, and tachycardia. See, alcohol works similarly to benzodiazepines. Each enhances the effect of GABA in the nervous system. If the enhanced GABA state is maintained for any period of time, the body will attempt to regain homeostasis by desensitizing the GABA receptors. Then, when the source of the GABA stimulation runs out while the GABA receptor is desensitized, very little to none of the GABA has any effect on the receptor. And since GABA is the brakes of our nervous system, now the brake lines have been cut. Everything that tells your nervous system to calm the f*** down is gone. This causes hyperexcitation of the nervous system, i.e. tachycardia, hypertension, tremors, and seizures. But with the proper benzodiazepine therapy, these symptoms can be controlled. Question 29. After flushing an IO with 10 milliliters of normal saline, consider lidocaine at a dose of 40 milligrams before starting an infusion. So IO stands for intraosseous and refers to the placement of a catheter into the patient's bone marrow. It's usually employed when the patient's life depends on the administration of a medication or fluids and IV access could not be obtained. Of course, the methods used to accomplish this goal are not always the most fun for the patient. However, placing the catheter is not even the most uncomfortable part. The medication or fluids need to burrow a path through the bone marrow. This can cause pain, and this is where lidocaine comes into play. Lidocaine is a local anesthetic. It works by blocking nerve signals at these sodium channels. These signals include pain signals. So you're going to give the patient a lidocaine bolus at a dose of 40 milligrams. The concentration is a 2% mixture, and you're going to give this before starting a fluid infusion. This will make the patient hate you less. All right, lastly, we got question 30. Nitroglycerin and morphine should be withheld from patients who show either ST depression or elevation in lead V4R while med control is contacted. So when you have a patient experiencing chest pain or other cardiac related symptoms, one of the first things you're going to do is obtain a 12-lead ECG. If you see ST segment elevation in any of your inferior leads, that is leads 2, 3, and AVF, then there's a good chance that the patient is experiencing an inferior STEMI. Alright, so here we have our heart and the coronary arteries. The posterior descending artery supplies blood to the inferior wall of the heart. However, the posterior descending artery gets its blood from the right coronary artery. More often than not, the inferior infarct is caused by an occlusion in the right coronary artery. This is why we need to do an ECG to check the right side of the heart. And also note that in a minority of people, the posterior descending artery gets its blood from the circumflex artery. So let's take a look at a 12-lead ECG for an inferior infarct with right ventricular involvement. First, we need to confirm that it is an inferior infarct by looking at leads 2, 3, and AVF. As you can see, there is significant elevation in all three of those leads. You can also find reciprocal ST depression in lead AVL. Now let's take a look at how this ECG hints at right side involvement. The first indicator is that we have disproportionately greater ST elevation in lead 3 as compared to the elevation we see in lead 2. We can also see that we have ST elevation in lead V1. So let's review. We can say we have an inferior infarct due to the ST elevation in leads 2, 3, and AVF. We can also add in that we have reciprocal ST depression in lead AVL. And now we can say there's a high suspicion for right side involvement due to the disproportionately greater elevation in lead 3 compared to that elevation in lead 2, and also there's some ST elevation in lead V1. It's also important to note that the right coronary artery not only supplies the right ventricle with blood, but also the SA and AV nodes, aka the pacemaker of the heart. For this reason, you can expect to see the patient presenting with bradycardias, heart blocks, and other rhythm irregularities. Getting back to our ECG, to be sure of right-sided involvement, you must perform a right-sided ECG. And if you don't have time to place another 6 electrodes, a V4R will suffice. To capture a V4R tracing, you need to remove the V4 electrode and place it in the same anatomical location on the patient's right side. You can also leave the V4 electrode in place and just use another electrode. The V4R electrode will be placed in the 5th intercostal space at the mid-clavicular line. Finding ST segment elevation in lead V4R is 90% accurate in diagnosing a right ventricular infarction. When you get your tracing, be sure to label V4R on the ECG. As damaging the right ventricle can lead to hypotension, it's important to be cautious in giving any medication that can lower the blood pressure of your patient, such as nitroglycerin and morphine. So finally, after 2 weeks, that wraps up the in-depth review of flashcards 21 through 30. Around this time next week, we'll have another episode for you with the rapid fire portion of flashcards 31 through 40. If you got anything good out of these videos, please do me a huge favor and hit the like button. It helps more than you know. And if you'd like to get these videos regularly to help you pass your exam, make sure you hit the subscribe button. Thank you guys for joining, and I'll see you next time.